All right, great. So I'll begin by thanking you guys for taking your time to attend this presentation. Let me just turn off my camera so that the connection can be better. All right. So I'm sure we've all had our fair experience with hearing the terms CT and MRI scans and even looking at them. And to me, at first, I was very curious about what they are and how we use them. So hence this hopefully simple presentation for you all. So my name is Mohannad Elgamal. I'm a fourth-year medical student. And let's talk a little bit about what this presentation contains. We'll first start talking about computed tomography scans or CT scans and what they are, how they work, the differences in them, and how we can differentiate between the differences and what they're used for mostly. Same thing too with the magnetic resonance imaging or MRI scans. We'll look at the different types of sequences and we will look at the differences between them for sure and compare them and when we use each and every one. And then we'll talk about the differences, obviously, between CTs and MRIs, and we'll have a few cases at the end to go over together. Please feel free to ask questions at any time and participate. I'm going to be asking questions. You guys can type up the answers or just unmute your mics and type. So let's start with the CT scans or computed tomography. So computed tomography, from the name, basically indicates these X-rays or X-ray radiation emitting in a 360-degree fashion and has a parallel detector on the opposite side, and it just spins around the subject and takes multiple 2D images. Usually they're millimeter thin slices, and then all of that is computed by an algorithm, a very sophisticated algorithm, to determine what the X-rays have detected. Now, these here on this image, you can see we have an anatomical slice on the left with all the different organs and the different tissues. And what happens is it takes a, let's call it an area, here it's called a voxel. Each voxel is just taken by the computer and the density of it is recorded, and that is translated into a shade of gray as a pixel. And the shade of gray is determined by a unit of measurement called the Hounsfield unit, or HU. So that unit of measurement goes from negative 1000 to positive 1000. And anything at the negative 1000 will appear completely black, and anything at the positive 1000 will appear completely white. And that determines density, the density of the tissue. Mind you, density is one of the terminology used to describe certain findings in a CT scan. So when you have something with a higher density, that means it's absorbed higher levels of radiation, and it would have a higher attenuation, thus it would appear more white, versus something that is just completely empty and doesn't absorb any radiation. So if we take this into an example, here we have on the right a chest CT scan. And if we put this down into a scale and we start all the way from the left with something around negative 1000, it would be the air. So air is negative 1000 HU units because it does not absorb any radiation. And as we go up the scale, we'll start to see tissue like fat. And I hope you guys can see my pointer, but I'm pointing at subcutaneous fat here on top of the chest. As you can see, it's not entirely black. It has a little lighter color to it. And then water and fluids, usually just clean water, clear water, would be around 0 Hounsfield units. And then as we go higher with soft tissue, would start to appear a little brighter. So you can see here, for example, on the back and around the scapula, you have the muscles. They appear a little brighter. And then bone is usually also most of the time the brightest thing you'd see in the body, and it's around 400, 600 Hounsfield units. For example, here you can see the vertebral spine and the ribs and part of the scapula. They all and the sternum up here. They all appear to be the whitest. But the whitest thing you'd ever see in a CT scan is, for example, like a metal artifact. So if a patient has any prosthetics or metal plates or screws put into their bones, they will appear the whitest for sure. So now we've talked about the different shades of gray, but we should also discuss the different, let's call them angles, that you can take of a CT scan. So the one we just saw is called an axial plane, where you cut through a person transversely, and you can see 4 directions basically of that person. So you have the anterior and the posterior side of the patient, and you have the lateral and medial sides, but we can't determine superior and inferior sections from this axial plane. And it's usually the most common CTs I've personally seen. You would look at them all the time, but you can also have different planes to help you locate something. And another example of that plane would be a coronal plane. So a coronal plane is just cutting through a person sort of from front to back. And you can see the sides of the patient and the top and the bottom, so the superior and inferior of the patient, but you can't really see the front and the back. You could only see the other directions. So here, we can see some of the organs. We can see the shape of the lungs. We can see sort of parts of the ribs and part of the heart and so on. And then third, we have the sagittal plane, which is cutting through a person side to side. And this right here is a mid-sagittal plane, so it's exactly in the middle of, it's not exactly in the middle, this is a specific one, but I'll show you one that's exactly in the middle. And like I said, it helps you see the anterior, the posterior, superior, and inferior aspects of the image. So I wanted to ask, does anyone know what this structure is here, the one I'm following with my cursor? You can type it out or just unmute your mic. Anyone?
Can you show it again, Mohannad?
It's this one over here. It's on the sagittal plane.
Let's see, descending aorta.
Exactly, you have descending aorta and part of the arch of the aorta. So can anyone tell me why it's white after we discussed the whole Hounsfield units concept? Why is this aorta white? What are the things that are supposed to be white, and how come this one is white? If you can jump to the answer, that would be great too. Yeah, we said liquid is usually around 0 Hounsfield units, so it shouldn't be completely white. So in this case, the reason the aorta is white is because this is a CT done with contrast. And contrast is basically a substance that is very dense or radio-opaque. Sorry, not radio-opaque. It's very dense, and it's usually, it looks like water, but under radiation it shines the brightest. And usually contrast is given to patients to follow the pathway of their vessels and determine if everything is right. So yeah, good job. All right, so this is another example of one of the planes used by CT scans, which takes the previous 3 we just discussed, and the computer just forms a 3D model of this thing, which is honestly really cool. And it's mostly used by surgeons who would want to have a better visualization of where they're going to, for example, incise, or how they're going to approach a patient's tumor, for example, or lesion or something. Can anyone give me another example of a plane that I didn't talk about? This one is not as commonly used, but it exists. I'll give you 5 seconds to say something. Oblique, yes, exactly. Good job, Mariam. So oblique is also I don't have an example of it, but an oblique plane is when you take an image at a certain angle where the body isn't sort of upright or lying down. And it's mostly used to determine certain features that are that would appear, I guess, more prominently at a certain angle. It's used a lot by MSK surgeons or even neurosurgeons, but it's not as commonly used. And sometimes you have no other choice but to take an oblique image if the patient, for example, is unconscious or they have some form of deformity. Then you have no other choice but to take that. Moving on. So now we talked about the different planes. Another important part of CT scans is called different windows. And when I say window, I'm basically talking about the different ranges between your Hounsfield units so you can see different things. So if we start on the far left here, we have a soft tissue window, which is usually the most common CT. It just starts off defaultly at a soft tissue window, and it goes from -125 to 225. You don't really have to know the numbers, just understand that it's more near the middle. So things like fat and soft tissue appear more clearly. But other things, for example, like air, would appear completely solid black if you see around the patient and inside the lungs of the patient, would appear solid black because it's not really part of the, the window. So if we want to look at the lungs and we want to look at the parenchyma of the lungs, we need to approach the main volume of the lungs basically, which is usually air. So we would have a much lower window but with a higher range. So we would have a lung window. So this center image is a lung window. As you can see, the tissue of the lung itself is a lot more apparent. You can see the vessels. If there's contrast, you will definitely see the vessels a lot better, and you will see some of the bronchioles as well. And you can see the window's a lot bigger, but it's more towards the negative side of the scale. And that's very useful in diagnosing lung diseases. For example, this was the most commonly used window when radiologists and other doctors were diagnosing patients with COVID. They would use a lung window to be able to detect the exact lesion caused by the virus. And then if we move to the complete opposite side of the scale, we'll go to a bone window. It's a little smaller than the lung window, but it's more towards the positive side, and that helps determine the densities of the bones themselves. So everything else looks a lot darker, but the bones kind of stand out. This is obviously very useful when there are any fractures that the doctors suspect, or you want to see the general health of the bones, if they're as strong or and as dense as they should be, they have enough calcium or not to determine certain diseases. So windows are used very commonly, but it's always dependent on the case and dependent on the situation itself. So here I have a nice example of a chest x-ray, and it's also labeled on one side to help you guys orient yourselves. So can anyone tell me what the top middle plane is? What's the name of this plane? Frontal is correct. It's called coronal or frontal plane. It's coronal plane. And can anyone tell me what window we're at? What window we're using? I told you it's the most common window, so if you pick that up, you'd be able to tell. And you can obviously look at the tissue themselves. Exactly, this is a soft tissue window. So you can see the soft tissue is very clear. If I scroll down, we'll be able to see the tissues in the heart, the muscles in the back, the breast tissue in the front, all the fat and so forth. All right, so here's a great example of a chest CT, and it's on the right. You'll have it labeled if you're a little lost, but it's good to help you. With an axial plane like this one, you might feel a little bit lost, but there are definite anatomical features that help identify where you are. So right now, where we are right now, can anyone probably guess or tell me which vertebral level we're at? And if this is too advanced, then it's okay. And obviously use the tissues and the structures around to be able to tell which vertebral body this is most likely to be. I'll give you a few seconds for that, and then I'll just answer. Okay, so you can see here, if we look at the trachea, you can see that the trachea begins to bifurcate. So here it's completely one solid, and then over here it begins to bifurcate. So we all know the bifurcation of the trachea is around T3 and T4. So that helps orient you if you don't have this obvious guided coronal section to know exactly where you are. And then you can tell that this is the ascending and descending aorta and so on. Other structures obviously wouldn't show so clearly, especially if they're collapsed. So for example, here you can't really see the esophagus, but as we go down, you'll see that it starts to fall. But if you've done your anatomy well, you'd know that it's always posterior. It's almost right in front of the spine, and it's posterior to the trachea. So here it's labeled sort of, so you can follow it and go and see how it moves posteriorly and then laterally to the stomach. And obviously you can see the heart tissue. It's all labeled here on the side, so you could just go through that. You can see the trachea split into the bronchioles. So CT scans are helpful at looking at soft tissue, more or less just a general version of them. And you have all these different shades of gray that help you determine if anything is different than it should be and so on. And with the soft tissue window, it's even easier to look at them. All right, so I'll move on from this. I'm going to upload this lecture for you guys, so you can feel free to scroll through this however you please and look through it. So we talked about the different windows, we talked about the different planes. Now we'll just quickly talk about some different types of CT scans that are a little more advanced and used in specific situations. And the first one that popped to mind to me was a PET scan, which is a positron emission tomography or a positron emission CT scan. And what happens here is basically a patient is given either they swallow or they get infused with a tracer, it's called, which is basically radioactive glucose, and it's called fluorodeoxyglucose. And the patient's injected with this glucose, and what happens is it travels along the body, and it usually collects around an area with very high chemical activity. And that helps determine things like tumors or any heart diseases or disorders. And usually a CT scan would be done of the entire body. And then the computer sort of picks up on the radiation emitted by this glucose and translate it into this beautiful, colorful thing. So here on the right, I have an example of a very interesting study I saw done in UCLA, where it compared retired football players and military personnel's PET scans, and they found that they both had history of memory loss and mood swings, and they've all sustained head injuries. And I can't really read the PET scan for you, but this helped determine a whole new sort of criteria or category of disease called a chronic traumatic encephalopathy. And you can compare, Alzheimer's patient control to like Alzheimer's in football and military personnel, and you'll see they'll have features of either a lot of activity or very little activity. Next, we'll talk about CT angiography. It's also a very commonly used form of the CT. Specifically, it focuses on live imaging, and it would be done by, for example, an interventional radiologist, where they would be injecting dye into the patient and following down the arteries, for example, with a catheter, and injecting dye to help guide them where they're going. And usually the dye is injected as they take the images, so you'll be able to determine the phases of the blood going from the arteries to the veins, for example. And this is used in situations where they suspect there's any stenosis or like narrowing of blood vessels or any aneurysms in the brain or any abnormal like movement of the blood, or even sometimes you can like tell if someone's bleeding by seeing it leak and things like that. And here I have listed the different phases when you inject. Usually you can only catch the arterial phase, for example, in a head CT angiography. You can only catch the arterial phase in the first like 30 seconds. So they would usually do it, and it'll be a 360 thing. The machine would spin really quickly around the head, and then as the dye is being injected, and record the arterial phase and the venous phase. And then the computer can even make a beautiful 3D image where you can like follow around and stuff. So here on the right, you see an example of the heart. Moving on, so that's pretty much more or less all you could know about a CT scan. So why would someone request a CT scan? The most obvious answer is that it's very fast. A normal CT scan takes about 10 to 15 seconds, and it's painless. You wouldn't feel the radiation or anything like that. There's no intervention, more or less, unless you're going to be injected with contrast. But other than that, there's almost no intervention, also unless you do a very special like CT. And it's a lot more affordable because it's technically just X-rays, but it's a lot fancier, and more computers are involved. And it's very important when it comes to determining details about the bones, the blood vessels, and most soft tissues. It's usually used as the first line of imaging when it comes to a emergency situation, trauma situations. An emergency situation could be like an appendicitis, for example, and you want to just determine that you can pick up any signs of inflammation or swelling or obstruction, things like that. And also like infectious diseases, like the best example would be COVID-19, where you do a chest CT, you'd go using the lung window, axial plane, or all the planes. You should usually use all the planes. And it's also very useful if you remember the 3D rendering would be, for example, a perfect tool to use to locate the exact position and size of a certain tumor or lesion or bleeding or hemorrhage, for example, or whatnot. Right, so now we talked about why we would use a CT, but when would we not use a CT scan? So one of the most important things is that we have to remember that this is actual radiation, and we are, and here you can see that one CT, chest CT is around 390 times, taking a chest X-ray around 390 times, and here on the graph you can sort of compare them. Second of all, it's contraindicated in pregnancy because of a risk of genetic mutation. And also some patients, if they have any kidney problems or acute kidney injury, the contrast is contraindicated. So you'd have risk of contrast-induced acute kidney injury. And another important thing, just talking back on the fact that you're exposing your patients to radiation, is to make sure that you're requesting a CT appropriately and within the appropriate time, and you're not over requesting it. This is an also interesting study that I will just simply summarize, saying that about 5% of people have done over 23 CT scans in their lives in a period of 22 years. And 7% of them showed a 1% increase in their cancer risk. I know it's a bit too many percentages, but long story short, there is an increase in cancer risk. This was done in the States, so it was a bit more specific towards the States. All right, so that's all for CT. Let's quickly go through MRI. So MRI stands for magnetic resonance imaging. And what happens is you basically create a magnetic field that aligns all the hydrogen ions or protons in your body. And then that process is called magnetization. And then this alignment is interfered by a radio frequency. And that radio frequency is usually like a rapid pulse of radio frequencies all at once. But when that frequency is emitted, it sort of forces the protons to move back to their natural alignment. And when they go back to their neutral alignment, they emit their own radio frequency energy or RF energy. So if you look here in the image, we have like the magnets and the coils, but we also have like RF detectors. So one of them would emit and the other would detect, and it would pick up on that specific frequency. And the different shades of gray identify different intensities of that tissue. So how like intense it was for them to, or how intense the emission of that RF was. And usually a normal MRI would pulse, or sorry, the magnet itself would create a field of around 1.5 Teslas. But actually recently I saw the most advanced, I guess, or the most recent MRI goes up to 10.5 Teslas, which is amazing. And that helps reduce the time it takes to do an MRI, and it's obviously a lot more detailed. I think in City Hospital, they have like a 5 Tesla MRI, which is pretty cool as well. Anyway, so MRIs have different sequences, right? And that depends on how these magnetic pulses are interrupted and the frequency between how they're interrupted. I have a lot of like descriptions on the left, but long story short, the T1 weighted scans are the most basic, I guess you could call them, most basic form of MRI, and they have a lot shorter pulses of RF energy and detection of that energy, right? So it has a shorter time of echo, which is sort of the time it takes between each RF pulse, and then the shorter repetition time, which is the like frequency of how it does it. So that's a T1 image. You can see here on an MRI, the brain, the soft tissue of the brain itself looks a lot more detailed, which is sort of the advantage of MRIs. They pick up soft tissue a lot better. They're done very commonly of the head. That's why I used it as an example. You can also see that, for example, does anyone know what this white structure around the brain is? Close. No, it's not the meninges. This is actually the skin. This white structure is the skin. Bones on MRI show as black. So here it's actually the skin, but yeah, trick question. The skull would be the black one around. So it's the most superficial, it's actually the skin. All right, anyway, so now let's move on to the T2 weighted image. So yeah, it's fat. It's the fat under the skin is what it was, to be specific. So a T2 weighted image basically has a longer time of echo and a longer repetition time, so it picks up on things a lot better. So you can see it, if we compare the two, it's a lot brighter than the T1 image. And I'll talk about the differences between T1 and T2 later on. Another type of MRI is called a functional MRI, and what it does is basically records the level of blood flow and the blood flow requirement in certain tissues. It's usually done for the brain, and it assesses brain function. And here you can see the difference between like a PET scan, a T1 MRI, and a functional MRI. And it's useful in determining whether, for example, areas of the brain are not getting enough blood or if they're getting too much blood. So it tells you like the activity and the function of the brain, whether it's functioning properly or not. Moving on, another important thing that the computer does for the MRI is that if you can see here in this image, the one I'm showing you guys, you can see that most things are around the same color. They're all around this almost the same shade of white or gray. And that's because they're all more or less around the same intensity, but they're different tissues. So what a computer can do is suppress or cancel out certain specific densities in tissues. And that way will help you. If you look in the bottom, you'll see a suppressed image, and it will show the differences between the organs a lot better. And this one on the bottom right here is a fat-suppressed T1 MRI. So subcutaneous fat is one of the most common used suppression techniques, I guess, to help determine even if you have like a tumor or a lesion. This will help determine whether it's mainly fatty or mainly blood or mainly a certain type of tissue and so on. So it's very useful in determining the pathology of certain tissues. So here I have a couple examples of the different types of suppressions. A FLAIR MRI, fluid attenuation inversion recovery, it's usually just called a FLAIR. A FLAIR MRI is a fluid suppressed T2. So if you look here on the right, you have a T2 image, and then down here you have a FLAIR. And you can notice the whiteness, the bright white around the brain and inside the ventricles of the brain, which is usually cerebral spinal fluid, is suppressed because it's fluid, so it's suppressed. And that's, very useful when it comes to determining certain lesions of the brain. And another example is a STIR. A STIR is a fat suppressed, similar to the one we saw before. And you can see here, for example, the fat under the skin always went suppressed when we did a STIR image. And another example is diffusion weighted image or a DWI. A DWI usually just detects the movement of water, and that helps a lot in also understanding, for example, if there's an ischemia somewhere, when there's a little fluid or little water moving around. So it's used in, for example, ischemic strokes and so on. And the brighter it is, the higher the fluids, or if there's no diffusion and there's an increase in the intercellular fluid movement, then you'd have a brighter signal with the DWI. Anyways, moving on to the differences between T1 and T2. When you look at a T1, we said the T1 has a shorter range, a shorter pulse or shorter frequency. So you'd see that the most distinguishing feature between a T1 and a T2 would be that fluid would appear dark. So if you look here into the spinal canal, you'll see that all the CSF just appears dark. Even in the peritoneum or retroperitoneum, things would appear dark as well. But with a T2 image, the most distinguishing feature between it and a T1 is that fluid appears bright. So you can see here in in the spinal canal, fluid appears white. So that's a very good take-home message, because I'm pretty sure any doctor or radiologist could just point at an image and tell you what is this image. So you'd want to look at areas of the fluid to be able to determine whether it's T1 or T2, but don't be fooled, because it could be, for example, fat suppressed T2, and you'll say T2, but it's actually like a STIR or something like that. So what are the type of tissues that appear bright on a T1? Things like subcutaneous fat, which we talked about. A hemorrhage would appear bright on a T1 image. Any melanin or any magnetic substances will definitely appear white on a T1. And if you look at the things that appear bright on a T2 are very similar. It's also subcutaneous fat and hemorrhages, but the main difference would be like water or edema or an inflammation caused by an infection, because there's edema there usually if there's an infection. So those things would appear white. Right. So in summary, these are all the different ones. You can go through them one by one and from left to right, just compare them. So you can see when you have like a fluid suppressed image of a T1, it's not very different than a normal T1 because fluid's already sort of suppressed. But if you compare a fluid suppressed image of T2, you can see that all the white basically completely changes. And here you have the fat suppressed, and you can tell because, for example, the skin is completely darkened or more or less darkened. All right, so here I have another scrollable image for you guys. This is the lumbar spine in T1 and T2, and it's labeled here on the side to help you orient yourselves. And if we go around the middle here, I think it's more or less in the middle, you can see the spinal canal is dark, but here it's white. And if you look at this middle image, you'll notice that here you have a stenosis. So right there, there is a spinal canal stenosis. If I go back to the normal, these two on the left and right are normal. You can see that it's usually very wide, and then here it's normal. So this can usually be picked up by either a T1 or a T2, but you can see how easier it is to pick up a T2. And other than that, you would look at all the other organs and structures. You can see that you can spot like the ligaments and the muscles of the back. All the soft tissue is a lot clearer on an MRI than it is, for example, the CT scan. All right, so let's look at this case, for example. So this is a T1 image of a 58-year-old female who was having dizziness and blurred vision, and she was worried about her previous disease sort of recurring or relapsing. So here's the T1 image, and we said T1 flare, more or less the same. If you look at the T2 image, you can see even comparing it to the T1, you can pick up some spots, tiny spots around the brain. But we want to even take this the next step. So we would fluid suppress to see if these spots are actually CSF or CSF spots or not. And if they're still appearing here, then they're not CSF. They're more of a lesion. And even with the stir, you can see, even if you suppress fat, they're not fat-based lesions. And this is a classic representation of, does anyone know before I spoil it? Can anyone guess what this is? MS, exactly. Good job. And so this is multiple sclerosis. So this is a relapsing. I guess this isn't. I wouldn't be able to tell if it's relapsing. For the most important thing is comparing it to a previous study. This is just one of the studies, but it's a very interesting paper talking about all the sorts of different MRIs used in the brain. Okay, so that's more or less a lot of info about MRIs, I know, but now we got to the part of why MRIs are important and why we would use them. So they're also extremely, sorry, not extremely, but they're also painless in the sense that there's no sense of intervention. It's not a procedure per se. And it's also, if you've noticed, we didn't talk about radiation at all. So MRIs are safe when it comes to that aspect that there's no radiation involved. And as you notice, you can even tell if you go back and forth, or when I show you the comparison, you'll be able to tell that these the soft tissues and anatomical structures are a lot more defined and accurate. And you can see organ tissues and soft tissues and organs and ligaments a lot better. So it'll be useful when you're assessing these specific things to do an MRI. And you have all these different sequences with all these different benefits and can really help a physician pick up exactly what it is with the example we did before of MS. And then the sort of disadvantages of MRIs is that they're not as available as CT scans, for example. CT scans are usually everywhere, but MRIs are not as available in most countries. They are very, very expensive, which is a big issue for most people, even for insurance companies. You have to have the insurance company to accept your MRI request before you go through one. And then another big disadvantage is that it is basically a giant magnet. So any patient with any form of metal inside their body, they are not allowed to do an MRI. It's more harm than good. So things like dental crowns, any bone plates or screws, or even pumps or devices like pacemakers, then the patient can't even be inside the room if an MRI is on. Another disadvantage is that they're sort of tunnel shaped. So a CT scan is more of a giant donut, but a MRI is a tunnel, and you go all the way in, and it's very close to your face, and it can be very claustrophobic given the fact that you have to sit there for an average of like 1 to 2, maybe even 3 hours. So yeah, that's the sort of downside of MRIs, is that they take a long time, and patients, for example, with MS have to do them at least once a year or every couple of months. So it can be very claustrophobic and very irritating, especially, it goes without saying, you have to sit very, very still so that you don't shift and change the anatomy of your body. And there is a small risk when it comes to pregnancy, but it's not as like significant as radiation. And usually, as long as the female is over 12 weeks pregnant, then it's fine. And of course, there's a risk of contrast-induced AKI, like in CT. It's just like a risk you have to keep in mind for sure if you're going to use contrast with your MRI. All right, now let's compare CTs and MRIs. So quick summary, we said CTs and radiation, and it's 360, it's X-ray radiation, goes 360, and it's usually used when you're assessing traumatic injuries, any fractures or large hemorrhages or large tumors, and you're trying to detect them. It takes about 10 to 15 seconds. And there is a risk of radiation if you're going to do it frequently or if you're a pregnant woman. And it has a short, accelerating, rotatory noise to it. It just sounds like something spinning really fast, almost like a washing machine or an airplane, I guess. But yeah, and then an MRI, we said, is a magnetic field interrupted by radio frequencies. And it's a lot more defined and precise at picking up soft tissue and organs. But the downside is that it's very slow and it's very expensive, and it could take 2 to 3 hours. And any patient with a metallic insertion would just not be allowed in there. And pregnancy could also be like downside. But yeah, I have actually audio right now for you guys to listen to. So I'll play the CT, and then I'll play 2 different versions of the MRI. So maybe turn your mics, turn your speakers up and just listen. Right? 3, 2, 1, CT scan. Yeah, I hope you heard it accelerate a bit and just start to spin faster and faster. If not, again, I'll be uploading this so you can listen to it in your own time. And then here I have the MRI sound. Bear with me, it's a little annoying. Imagine going through this for 2 to 3 hours. You know, put yourself in the patient's shoes, but it goes something like this. And it would stop for a bit, and then it would go something like this. Just stop it now for the sake of time. But yeah, you can like always go on YouTube and just listen to these different MRIs and even CT scans. I saw a pretty cool like 360 sort of virtual reality CT scan sort of patient situation. Anyways, putting them side to side, can anyone tell me in the CT scan what window we're looking at? All right, I'll just skip to it. So this is a bone window, yes. So you can see all the other tissues more or less look the same, but the bone window, the bones are very like clear. And can anyone tell me what MRI sequence this is? It's actually a T1. It's actually a T1, not a T2, because you can see the spinal cord is here is dark. But the MRI itself generally looks brighter because of some contrast adjustment. But I just wanted to find a perfect image of comparing a lumbar spine for both of these. So you can see here the bones in the spine are very clear. You see the different attenuations or densities between them. Between the different tissues, and you can see the general anatomic structure of the patient and their like spine. But with an MRI, the soft tissue, I know it doesn't show as much here, but soft tissue in general is a lot more defined and prominent. So you'll be able to focus more on the like IV discs, on the spine itself, the spinal cord itself, any like ligamental issues and so forth. So here you have them side by side. And then here's another example of a CT versus MRI. We talked about things like here you see bone as white, but here bone appears black. Does anyone know what sequence this is? It's sort of a combo of two. This MRI, sorry, on the right. I'll just say it. It's a T2. It's T2, but it's fat suppressed. So you can see that the fat is suppressed around the skin, doesn't seem as bright. So it's fat suppressed T2 or a stir T2. Right, so let's look at the differences. We talked about the bone. You can even look at white matter here. White matter appears dark gray, but here it's sort of hypo intense, which is also technically dark. You can see the CSF would be black because it's technically fluid, so it doesn't absorb as much radiation, so it would appear black here. You'd see the CSF in the ventricles, in the anterior and posterior horns of the ventricles. Right, and then, you know, with CTs, you have these different windows. We discussed this would be a more of a soft tissue window. Here we have different sequences, and this we said is a T2 stir sequence. All right, so I just included this slide to mainly discuss appropriateness. And if you're ever curious about the appropriateness of requesting a certain study, you should definitely hit up American College of Radiology. They have manuals and guidelines for the level of radiation, for example, with a CT scan, and for example, the time it should take between every other CT scan you're going to do, and how it affects different parts of the body differently. So like an abdominal CT scan is a lot more radiation than just like a bone or a hand CT scan or a like shoulder CT scan, for example. There are no like generic guidelines. It's not just like a given say. It always depends on the case, depends on the suspicion, the diagnoses, all those determined. So I couldn't just give you a basic answer to what is the right time and so on and so forth. But it's very important to hit up the American College of Radiology to study appropriateness, because, you know, in the future we're going to be ordering our own studies, and it's important for us to put the patient's overall well-being in mind and make sure we're not overexposing them or exhausting them, for example, in MRI by doing multiple MRIs of different parts of the body in one day, things like that. So it's very important to keep these things in mind. All right, so we're more or less done. Now let's just talk about a few cases. I really would appreciate if you guys participate. I'm not gonna like grade you strictly or anything, but yeah, so let's start with our first case. So our first case is a 40-year-old man. He presents to the emergency department with severe acute abdominal pain. And the pain started about 2 hours ago after a fatty meal. It was very sudden, it was very intense, and it was just getting worse and worse. And it was more of epigastric / right upper quadrant pain, and it was also radiating to the back. So that's called Collins sign, which is positive, and Murphy's sign is also positive. So does anyone know what is there a differential? Does anyone have any idea what this could possibly be? I honestly gave you a lot of the answers.
Did he have any fever?
No, he didn't have a fever.
I have cholecystitis and pancreatitis in my differential.
Yeah, so you're right. You're closer with cholecystitis, and pancreatitis is also a good suspicion because they share a common bile duct. So you would definitely keep that in mind. So yeah, that's great. So what would be the first choice of study you're going to do, given history and physical and like blood tests? What else would you do? Talking more radiology here.
I would go for ultrasound.
Correct. So that's technically, you're right. You would follow the guidelines and do an ultrasound. That's perfect. Usually an ultrasound is just faster. It is non-invasive. There's no radiation or no, long hours of waiting, because this is sort of an acute or an emergent sort of situation, right? So yeah, an ultrasound would be appropriate. Now let's assume an ultrasound was done on this patient and it was inconclusive because he was overweight or something like that. What's the next step? One of the modalities we talked about. Exactly. So typically you do a CT scan. Can you tell me why you think a CT scan is appropriate, Sayyid Ali?
To better visualize if there's a gallstone or impacting one of the ducts, for example.
Yeah, great. So that's a good reason as well. Even though we said MRIs are better at soft tissue, CT scans are still good enough. And also the fact that they are very quick would help in, determining what this is. So in case we have to send the patient to surgery and so on and so forth. And Mariam was right to a CT, but I would probably do it with contrast because it will help tell me if there's any obstruction or not. So a CT with contrast. But if the patient has like history of kidney failure or any kidney disease or I don't know, any problem with his kidneys, his family history or so forth, I'd probably do it without a contrast, but a CT would be very important. All right, so now let's look at his CT. Also, this is like a scrollable image, so you guys can do it. Usually when you do a CT, so can anyone tell me what this is, what plane and what window? I'll like keep it around here.
This is soft tissue.
This is between soft tissue and bone. You're right, but you can see the bone is a lot clearer, but you can still kind of distinguish between the soft tissue. A soft tissue window would be sort of brighter, I guess. You'd be able to tell like the difference between a liver and a heart. Here, the colors are more or less the same. I don't know why this is a bone window, but can anyone guess maybe why this is on a bone window? And yes, Varshini, you're right. It's a transverse plane, but it's usually called an axial plane. So it's an axial plane. So why is it around the bone tissue? So Ben, you said you suspect cholecystitis. So why would it be around the bone window?
Maybe you want to see calcium. You want to see stones better.
Exactly. Remember, I said calcium would be around 1,000, positive 1,000 HU units. So if you're suspecting for any gallbladder stones, you would do a CT, you would put it around the bone window to be able to tell. So here we can see his liver, we can see that there's content in his stomach. We see his spleen, and as we go down, we can even we see like a little cyst in his liver, but that's really not to worry about. And as we go down here, you see the structure over here. This is the gallbladder. We can see it's a little distended, but there are no stones in there. All right. And if we look here, this structure over here is the pancreas, and we can see it seems fine. If I put it around like right here, can anyone tell me if this image is with or without contrast?
It's without contrast.
I think it's with contrast. Do you see the kidneys and the arteries and the vessels coming out of the kidneys are completely like solid white? That's because of the contrast. So yeah, sorry, let me go back up. Yeah, we don't really like see it. Anyways, the reason you would say without contrast is probably because it's a bone window, so contrast wouldn't appear so clearly in tiny vessels, but a big vessel like over here, it would appear. All right, so anyways, moral of the story, we did the CT scan and the gallbladder was empty. There are no stones. So he was treated for cholecystitis, but he wasn't getting any better. So then the doctors decided we need to do an MRI scan. All right. So that's usually just the next step. So they do an MRI scan of his abdomen, and we have here the axial on the left and the coronal on the right. And as we go down, we can see the liver, we can see the stomach, and I want to find that cyst I told you about earlier. Here you can see the cyst we saw earlier in the liver, and here they're measuring the common bile duct. So we have the pancreas over here, and you find the common bile duct. And if you go right here, you can see that the gallbladder is actually completely full with stones. So this is one of those rare cases of a false negative CT scan where it doesn't show the stones. And that's just remember we discussed the whole bone window and trying to find calcium. It's because the most common stone would be like a calcium stone in the gallbladder, but these were not calcium stones. So that's why they didn't show on the CT very well. But you can see on the MRI, it's very, very obvious that his gallbladder is full of stones. So yeah, and if we look at the coronal here, you can see the gallbladder is all distended and filled with stones all the way. And if we go here, we can even see the common bile ducts is a little dilated as well. But yeah, we can see here the main vessels are not like solid white, so they're not with contrast. Yeah, so it's a very interesting case of a false negative. I know I'm probably a little of a trick question, but you guys are on the right track of what modalities to do and what you saw there. So yeah, very interesting case. It's always important to like trust your gut and trust your history and physical. If he had positive, like a positive Murphy sign, positive Collins sign, then it's most probably his gallbladder. And even if a CT scan didn't show anything, you could still trust your gut. You can't completely depend on radiology. It's obviously very helpful in certain situations if it was an obstruction, for example, but it wouldn't necessarily mean that you were wrong in the first place. That's why we have differential diagnoses and different possibilities. For the sake of time, I'll just move on to the next case. So quick case, 22-year-old male in a motorbike accident. He was hit by 2 different cars and was unconscious at the scene and was brought unconscious to the ER. His head is obviously bleeding, and he was wearing his helmet, but there's still some blood on his helmet, and it's a high impact force. So what's the first thing you want to do? Let's skip the history. You can't take history because he's obviously unconscious, and you can't. You can do a physical, but not very like well. For example, like a neurological physical. So what would you do first thing? What's the first thing you'd be worried about?
Non-contrast CT.
Good job. So yeah, you do a
Non-contrast
CT because you'd be very worried about any brain hemorrhages or any head injuries, any bleeding in the brain. So it's the first thing you want to worry about. It's probably why he's unconscious. So you'd want to rule that out, I guess, for the reason why he's still not awake. And it could also, for example, if he's bleeding in his brain or if there's any like a spinal fracture that could, like for example, like a spinal cord stenosis, you'd be worried that it would block his natural need to breathe or for his heart to beat. So all these things are very, very concerning. So yeah, it's the first thing you would do. So now let's look at his CT. So this is an image of a CT. I'm sorry, it's not scrollable, but this is an example of a CT. And you can see here, there's some lesions. So if I show you, there's like blood here surrounded by some edema. If we look at the CT a little bit, I think this is a little bit higher up. You'd see there's also some blood here in the brainstem. There's some blood even here in the horn of the lateral ventricle. So a CT is clearly good to show. If you look at the general structure of the skull, we don't see any like fractures. Usually you just switch to a bone window to help like determine if there's any like minor fractures. There's no obvious hemorrhaging to push against the brain. You'd have that what was it called? Mass effect. You can see his sinuses filled with air. All right. So after this CT scan, the patient, the doctors were more or less not so worried because you wouldn't treat this surgically. Let's just take it from a surgeon's point of view. So you wouldn't treat this surgically. You would treat it conservatively. You would put the patient in the ICU and just monitor him and make sure he's like breathing and he's getting better. And obviously treat other injuries, right? But it's been a week and your patient is still unconscious. So what would you do now? There's a theme to this, so you can easily pick up the answer. All right, so you do an MRI. So when they do the MRI of the brain, so before I move on to the MRI, we established that a CT was the appropriate thing to do, and it's the right thing to do for this patient, and it helped us determine that there's nothing serious to worry about, correct? So that's like, what would you do? That would just prove that CTs are great for the situation. But in this specific case, because the patient was still unconscious and the CT didn't show us any obvious, for example, contusion in the brainstem or anything like that, you would be worried, so you'd want to do a more thorough scan. So you would do a what's it called? MRI. So here's an MRI. This is the same lesion we looked at before in the CT. You can see it a lot wider and clearer here, and it's in the right basal ganglia. And yeah, so in the CT it looked more like a little bit of blood with edema, but on the MRI it looks like a lot more blood. This was about a few days later, so maybe it was still actively bleeding or getting a lot, clotting or something like that. And also, if you look in the lateral ventricle over here on the left side, you see that there's blood being collected as well. And if we look at the brainstem, you can see here this lesion's a lot bigger. This contusion is a lot bigger. If I go back to the here is just kind of like a dot, but on the MRI you can see it's a lot more concerning, and it could indicate why he's probably still unconscious. I had a question for you guys about the CT. I'll just go back. Can anyone tell me if the head is a little tilted? Can you guys see that the head is sort of facing to a sort of northwest angle? The reason it is because the patient presented, yeah, it's tilted more towards the left. And the reason this was done that way is because the patient was unconscious, so you couldn't really like ask him to hold his head up. And if you're suspecting any spinal injury or cervical spinal injury, you don't want to like tilt the skull. So they just sort of put him there as calmly as they can. But if you look at the MRI, it's more of an upright situation. So that's an interesting thing to point, because when you have the head tilted a little bit, it's a slight oblique angle. It could give you some oblique features, but it's not significant or different enough that you won't be able to tell. But some structures might look a little bit bigger than, like for example, I have another image here that I have the CT and MRI sort of compared. But here you see that the ventricles sort of look asymmetrical, but they're not that asymmetrical. It's more because of his head being tilted. So that's also something to keep in mind, the positioning of something like a head. Anyway, so if we could put the CT and MRI together next to each other, more or less around the same area, we'll notice that the MRI picked up these tiny infarctions and like slight lesion changes in the left anterior left frontal lobe and the posterior right occipital lobe. But you can't really see them on the CT. Some could argue that's because it's a more of an like oblique or not perfect like angle. Some could argue that the window isn't as appropriate. But I just wanted to let you know that yes, MRIs are a lot better, especially with tissues like brains, to indicate specific lesions, soft tissue lesions. But the CT, regardless, I know I'm favoring MRIs right now, but CTs, regardless, are very important in situations like this to pick up any, for example, extradural hematomas or subarachnoid hematomas or hemorrhages, or things like that. All right, so we've discussed this case more or less during the case. Does anyone have any particular questions, or do you want me to go back for this case? I have one more case. It's a lot more interesting, so you can just go to that. I'll just go to that. Save the questions till the end, sorry. Okay, so case number 3, very interesting and rare situation. A 27-year-old pregnant female was brought into the ER after a road traffic accident. So let's say she's in her 3rd-ish trimester, and she was wearing her seatbelt. She has no obvious external injuries, a little bit confused and shocked, but she felt the seatbelt tug really hard against her stomach, and she's very worried. So, all right, I'll get back to your question later, Roshni. All right, so again, in this situation, I'm kind of throwing you guys a curveball. I'm sure most of your instinct image of choice is a CT scan, because you want to make sure that there's no active bleeding or there's no dissection of her aorta or so on and so forth. But you're like, wait, Mohannad, she's pregnant. Right, so what would you guys do in this situation? Whoever is left. I know some of you have to go. I'm sorry I took so long. I understand. Thank you for coming.
Maybe we go with the CT after consulting different doctors.
Yeah, that's a good point, Said Ali, and I'll definitely get back to that. I agree with you as well. We should definitely still do the CT because if you think about it, there's no baby if there's no mother. Like we have to make sure the mother's alive so she can keep the baby alive. But I was honestly hoping someone would be like, oh, we could just do an ultrasound. And that is also a correct approach, especially by the guidelines. You would start off by an ultrasound if it wasn't a road traffic accident, if it was just like a traumatic incident. But you know, like 90% of pregnancy injuries are traumatic. And yeah, so anyway, so yeah, you would do an ultrasound, and the ultrasound would be appropriate if you want to assess the fetus before you do the CT scan. So you would want to assess the gestational age of the fetus, how many fetus are in the uterus, you know, if she's pregnant with twins or not, you know, in case, for example, she was unconscious and she can't tell you. And with the ultrasound, you can also assess, like I mentioned, the gestational age of the fetus, and that will help determine whether some radiation right now is too risky for the fetus or not at all. You know what I mean? Because remember, you're gonna have to convince the family that you know, get their, for example, if she's unconscious, let's say, to get their consent, or even her consent to do the CT, because normally you would see even right in front of the radiology ward they have like warning signs for pregnant women all the time. But right now we want to make sure she's not actively bleeding, and the for example, you'll see in this case her placenta is still intact, and there's no, for example, yeah, mostly it would be like any trauma, physical bleeding, or fractures that could have affected things. So anyways, enough talking from me. But the doctors, after taking her history and physical, definitely suspect a placental abruption. So this is a little not very comfortable to see, but you guys will see a CT scan of a fetus in this one. So I took, this was a very thin CT scan done, very thin millimeter slices, but I only took sort of the middle half of it because but I just wanted to discuss that in a situation like this, we don't want to forget that this was traumatic. So you would want to go through the entire body, make sure the liver is fine, the spleen is fine, the heart is fine, and so on. Make sure, you know, as a radiologist, you just want to go through the entire body appropriately and go through every little thing. So here you can see this is the bottom lobes, bottom sides of each kidney, and as we go down from there, we can see the intestine, we can see the subcutaneous fat, and I think we start seeing the uterus right here. But before we do, I wanted to show you guys there's some like subcutaneous. I think it was described as. Give me a second. Yeah, it was just described as a minor anterior inferior abdominal wall subcutaneous fat stranding, and this would usually happen because of like a seatbelt injury. So yeah, radiologists know if you wore your seatbelt or not when you got into the car accident for sure, because of signs like that. Anyways, let's go down to the uterus. So here we start seeing the uterus, and right now we start seeing the skull of the fetus. And as we go down, we can follow the sort of bone structure of the fetus. We got the rib cage, we've got the tibia and fibula over here, and you can see the sort of, you know, the femoral heads. I hope they show you the femoral heads. There's no like femoral dislocation, which is a very common injury during road traffic accidents. But let's focus more on the placenta. So the placenta is the structure of anterior over here. And you can see it was described as large areas of non-enhancement over here. So it's sort of basically lighter and not as enhanced. The placenta itself is described as a sort of cloudy, or not cloudy, but patchy, I guess, organ, which is not how it should be. So you have some anterior non-enhancements over here. And these are the CT signs of a placental abruption. That's honestly all I know about the case. I don't know what happened after, so I'm sorry if I don't have answers about that. But yeah, feel free to scroll through this case. But yeah, so let's discuss what Said Ali mentioned, which is, you know, taking consent from the patient and consulting other doctors about doing a CT because you're more worried about the pregnant mother than the fetus, because like I said, if there's no mother, there's no fetus. So this is just a quote I found that was very important, and you have to keep in mind that if there's no mother, there's no fetus. So yeah, so typically you would do an ultrasound first, and that way you'll be able to determine the well-being of the fetus and the gestational age, and then you would do a CT scan. I added some numbers here. Again, you guys don't have to remember them, but they're just important. So one resource mentioned that, like, American American College of Radiology was discussing how anything less than 50 milligrays was never, there was like a 99.97% of you know, no abnormalities happening to the fetus and no childhood cancer to the fetus. So anything less than 50 milligrays was typically associated with no abnormalities to the mother and no loss of pregnancy or loss of the fetus. And in this chart, you can see that anything above 50 milligrays for any age of gestational age is a bit risky, but anything less than 50 is just perfectly fine. And here I just put down for you guys to see that a normal CT of the abdomen and pelvis is around 25 milligrays. Milligrays is the unit used to determine the level of radiation absorption by a tissue or an item. So yeah. All right. So in this situation, doing a CT is not as dangerous as we discussed earlier, or how dramatic it could be, because typically, you know, you'd be worried about the fetus, the mother would be worried, and she'd be like, no, screw it, whatever, and you need to convince her, and you got some numbers here to help convince her. All right, sorry for the longer than expected presentation. Thank you guys for taking the time to attend. I hope you learned something out of this, and please let me know if you have any questions that I hopefully can answer.
Thank you, Mohannad. I really enjoyed it and learned a lot. Thank you.
Thank you,
And
guys.
guys, please fill in the survey.
That was
Thank you,
excellent,
guys.
Mohannad. I really enjoyed it too. I honestly have nothing to add. It was very comprehensive, and I like how calm you go through it. At the same time, you don't, you know, to keep the tone the same, so you keep people engaged. And obviously, there was a lot of effort put in. Everything you said was correct, and the cases are very interesting. Excellent, really. I would like you to comment about, I love how you discussed, it's always the hot topic of what you do when the patient is pregnant, how much, you know, what's the right decision, do we do it or we don't do it? So what I would like you to think about when you're deciding whether to do a radiological examination or not is always to think risk versus benefits. If you do the radiation protection course, they will teach you about first indication. So if you do have a valid indication, and for that you can use appropriateness criteria, then go ahead. But always it's risk versus benefits. So let's say I would be, my conscience will be clear if I'm doing a CT scan for a pregnant woman, although it is much more radiation than, and she needs it, than if I do a plain chest x-ray for a pregnant woman and she doesn't need it. If someone's telling me, okay, we're doing it for visa to Canada, my conscience wouldn't be clear doing a chest x-ray for her, even if it's 0.02 millisieverts. While if she was involved in a road traffic accident, I'm happy to do CT scan for her and even give her contrast, because I know that she needs it and that her benefit from this exam is will outweigh the risks. And that's the same for anything. So the same would be for MRI. We'll always try to choose the modality that is less harmful. There has been a lot of studies about using MRI for appendicitis, for example, in pregnant women, or even for renal stones. Although MRI is not the easiest, it's much easier to read CT scan for renal stone, for ureter stones, or for appendicitis. But it's worthwhile doing the MRI, giving it a try without harming anyone. So it's always put that scale in front of you and always think risk versus benefits. That applies to anything, also to medication that you're giving, right? Even to IV fluid that you're giving. Anything that you're going to give to your patient, always weigh the risk versus the benefits. Yeah. But honestly, it was amazing. I love it. The cases are excellent. Everything is good.
I appreciate it. Thank you so much, Doctor.
Well done.
Thank you.
Thank you.
All right, so I will probably send you guys a link on Teams. Sorry, let me turn on my camera so you can see. I'll send you guys a link on the same Teams chat of access to this presentation, so you can feel free to go through it whenever you want. If you just want to revise or scroll through, it's really fun to scroll through the slides and study your anatomy over again. So yeah, all right. Any other questions?
Thank you so much, Mohannad. We really enjoyed it, and hope to see you all in the next session, and everyone have a great day.
All right, thank you. Bye-bye.
Bye.